Hepatitis is an inflammation of the liver, can be due to a ton of different things. I'm going to talk about, of course, drug-induced causes of hepatitis, some common medications that are associated with that. Also, of course, going to touch on hepatitis as far as an infectious disease as well here. So hepatitis, again, inflammation of the liver, elevation in ALT and AST. So kind of normal limits of those are in the kind of 10 to 50 range as far as the normal levels there. We classically kind of think of, 3 times upper limit of normal as far as a problematic level or a level of higher concern. You will see quite a few patients with just mildly elevated LFTs that may be indicative of a fatty liver type situation. So keep in mind that, if it's just slight elevations, usually we just do monitoring, and that's not a full-out hepatitis type issue in the majority of cases. Common causes of hepatitis, so hepatitis A, B, and C. Drugs, alcoholics, and I've got another section of the webinar on cirrhosis, so you can kind of refer to that as far as the alcoholic side of things and some of the complications there. First off, we're going to talk about drugs. So here's tons and tons of drugs associated with the potential for liver issues, liver damage, liver failure. Okay, so let's state that first. However, you need to pick out some common ones that really may be strongly associated with liver dysfunction. And so I put together a small list here, and certainly there are others, but amiodarone, kind of a classic agent used for arrhythmias, rhythm control, definitely a black box warning there, need to monitor liver function with that medication. Isoniazid, tuberculosis, common medication used in the treatment there, and notorious cause of liver failure. RA drugs, all of these can impact liver function. So we got methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. Liver function is recommended to be monitored with all of these. Valproic acid, another medication there that can impact the liver. Rifampin can. Statins are another good example there. And I would say that statins aren't real common in causing liver toxicity. However, because they're used so frequently, certainly hepatitis can result or elevated liver function tests. And then the classic, which I failed to put on here, but classic example is overuse of acetaminophen, which can cause some liver issues especially at doses greater than 4 grams per day. Speaking about some of the hepatitis, the infectious diseases here, Hep A, so vaccine is available, so that's always an important thing to remember. Hep A is transmitted by fecal-oral transmission, so you could understand that, this could be a pretty rampant spread, and most often it's going to occur in third world countries due to poor sanitation and different things of that nature. Symptoms: mild fever, nausea and vomiting, muscle pain, anorexia. The GI symptoms are probably the most common, and you can understand how that gets transmitted then through dirty water, unsafe water. Usually self-limiting. In rare cases, it can go into hepatic failure. So supportive care is mainstay of therapy. There is immunoglobulin therapy that can be utilized. But again, if this is happening in third world countries, we might not have access to that as well. Hepatitis B. So this is blood, semen, vaginal transmission. Symptoms kind of similar to hepatitis A: nausea and vomiting, weight loss, mild fever. Many patients may have a few initial symptoms, flu-like, just not feeling very good, and then they may be asymptomatic after that. So what the problem that results from that hepatitis B infection is the immune system attempts to attack it, to solve that problem, and in doing so, it actually kind of attacks the liver along with the virus, and it can cause liver injury, liver damage through that route. Certainly, if there's enough damage, if it's substantial enough, it can lead to hepatic encephalopathy, coagulopathy, confusion, ascites. And I did want to mention that coagulopathy, remember that clotting factors are made in the liver. So if the liver is not functioning correctly, if it's damaged, those clotting factors may not get produced. So what does that lead to? So if we check a lab, if we see an INR or a PT and it's elevated, and they're not on warfarin or any anticoagulation, it could be due to poor liver function or damage to the liver if we see an elevated INR in a patient not on a medication that would cause a high INR. Risk of liver cancer from Hep B is possible, and there is a vaccination available there as well as Hep A. Drugs you may see utilized, so just a couple of agents here. PEG interferon alpha 2A. There's definitely a few boxed warnings. Autoimmune, infectious issues, which kind of makes sense that we're trying to suppress, trying to take out that infection, that it could cause some issues there. Other side effects: hair loss, GI, CNS changes are potentially problematic with the PEG interferon. Entecavir is a nucleoside type agent. Tenofovir is a nucleotide type agent. Lactic acidosis can happen, as well as further liver issues, unfortunately, with these type of medications. Hep C. So this is a blood transmission. Probably what you're going to see is it most happens in IV drug abusers. The other situation is we need to keep an eye on our patients that were born from 1945 to 1965, as they are at highest risks due to potentially previous transfusions, previous poor infection control techniques. Okay, so they may have been inadvertently exposed and now have been asymptomatic for much of their life, until maybe now later in life they're running into symptoms and problems. So Hep C, some cases will clear on their own, and some will have some chronic issues, some chronic problems. Direct acting antivirals are the drugs of choice here. So kind of the classic example medication is Harvoni, which you may have heard in the news as a super, super expensive medication, and lots of things going on with that over the past few years here. There is not a vaccine for Hep C, so we're going to need to do treatment there as far as that infection goes if it doesn't resolve on its own. Needle stick injuries, I think it's important to remember that. Hepatitis B and A, of course, vaccination issues. B is going to be more common in our in the U.S. anyway than hepatitis A, due to our good clean water supply. Post-exposure management. So if you have a healthcare worker that does get a needle stick, information gathering is going to be super important. What kind of history background does the patient have that we need to worry about? Patient exposure, Hep B, Hep C testing, identifying where that needle is coming from. If we can't figure out that patient's history for some reason, we must assume that they are positive for disease. And with vaccinations, particularly with Hep A and B, of course, we certainly can do an antibody titer, which is probably the best way to assess vaccination status and see if a patient is covered for Hep B, for instance. And then from there, we determine if post-exposure prophylaxis is necessary. Hep B's got immune globulin, so we can use that. If patients are exposed, healthcare workers are exposed by needle stick, for example, give within 24 hours of exposure if possible. So, if somebody's got a needle stick, we're obviously going to do our best to figure out what the game plan is and what to do quickly. 7 days at the latest is typically recommended. Hep C, monitor early treatment if a patient is infected. There is not an immune globulin product available at this time. Vaccination for Hep C doesn't exist at this time either.